Great. So I'm Ravi. I'm with the Diva Associates. I think Adam filled you in what this discussion is going to be regarding, obviously. Did you happen to fill out
the
screener questions, and you sent them back to Adam?
I did.
Okay, that's fine. I can get them another time. But let me just confirm a couple things that are important that I do need to know. On average, after transplant, are patients discharged around day 28? Did you agree to that?
Yes.
Okay.
Yes.
Okay. Great. And then you guys use the Glucksberg method?
Yes.
Okay.
Yes.
Okay, perfect. So before we begin, I just want to let you know that some of these questions are going to be repeated. They're not exactly repeated, but a lot of them are related. So you might be answering the question in a different question, basically.
Sure.
But I'm still required to ask every question. So if you need to repeat your answer for a different question, just ignore, go ahead and answer it. Ignore that you've answered it already, basically.
Okay.
Okay, great. And then, so we can get started. I do need to read you a disclaimer from our client. So we are required to pass on to our client details of adverse events, product complaints pertaining to their products that are mentioned during the course of market research. Although what you say will, of course, be treated in confidence, should you raise during the discussion an adverse event or product complaint in a specific patient or group of patients, we will need to report this even if it has already been reported by you directly to the company or the regulatory authorities. In such a situation, you will be asked whether or not you are willing to waive the confidentiality given to you under the market research codes of conduct, specifically in relation to that adverse event product complaint. Everything else you say during the course of the interview will continue to remain confidential, and you will still have the option to remain anonymous if you wish. Okay, perfect. So today we'll be discussing the prevention and treatment of acute GVHD, specifically in patients over the age of 18 and receiving an allo HSCT. And we're looking at an investigational product that is used for prevention and treatment of acute GVHD. So something to keep in mind, it's an IV infusion that can be given over 1 hour. For prophylaxis, it's 17 doses over 8 weeks. For treatment, it's 12 doses over 8 weeks. Do you happen to have the handout for your own reference?
Let me just pull it up. I know I have it somewhere.
Okay. I can also send it again.
I have it.
Okay, because there will be it might be easier for you to refer to some things on there, and I'll call attention to that when it's appropriate. So yes, so I know every patient undergoes conditioning. Does every patient receive it inpatient? Is there a split? Is there a patient type?
No, everybody receives it inpatient. It's part of the admission. So they all have like a treatment plan, which includes the conditioning, the GVHD prophylaxis, when is day 0, and then what happens after day 0 if there's any other supportive measures. So it's all outlined before patients come in, and so they usually come in the afternoon before they start their conditioning.
Okay, got it. And I had a respondent the other day. We've probably interviewed about 25 physicians already, and I had one respondent tell me that all his allo patients, his center, not his, but all his center's allo patients are done outpatient.
Yeah, so that's not normal, but there are a couple of places that are I think trying treatments that have historically been done inpatient as outpatients, and I think there's a certain setup that you have to have, and that setup has to be like really grounded in a really well-oiled machine in order to work. So I do hear about some auto transplants that are done outpatient. Allos are definitely less common, but I think there are some places that have the capabilities to try this, but that is definitely the outlier.
Okay, and your center does nothing.
No, never an outpatient allo.
Okay, great. And in regard to the 28-day average, how soon has your center discharged patients?
Yeah, so for people that get like a reduced intensity conditioning transplant, they often go home before 28 days. I would say maybe closer to 21 days. Okay. The myeloablatives do stay longer, but they're closer to 28. But the reduced intensity ones usually the transplant stay is relatively straightforward and protocolized. So they just leave, 3 weeks later, day 19, day 21. I think I had a day 19 one recently, like a year ago.
Mm-hmm. Okay. And if you can put a percentage on how many patients are discharged day 28 or prior, would you be able to do that?
Oh yeah. It's the majority. I'd say 80%.
Okay, great. And what criteria must a patient meet before being discharged?
So there's a few. The first one is that they need to have stable blood counts and not be like daily transfusion dependent, which is really only an issue for the myeloablative ones. And that's where, that timeline comes from a lot. The second is that they need to be able to have enough nutrition support, whether it be orally with their oral intake, or if they're also going home with IV nutrition like TPN. Mm-hmm. The third is that we have to have a sense of what their electrolyte needs are, especially because they waste so much magnesium from the immunosuppression. And so, we have to make sure that we can get them on a home IV regimen. So, like, for example, many of my patients will go home and then 3 times a week at home or 5 times a week, they'll get 4 grams of IV magnesium and a bag of IV fluid. So we just have to have that. We have to have enough data to be able to do that at home. And, usually that all kind of comes together around the same time. And fourth, of course, they can't have any uncontrolled, acute graft-versus-host disease or complications or anything like that, which is, most of the time that doesn't happen by then.
Mm-hmm. So if a patient does need IV mag, it sounds like, is that a majority of patients or pretty frequent at least, would you say?
Yes, most patients go home on IV infusions. Okay. And then we slowly, as we get further out, we start to wean their immunosuppression, then we can transition them to oral. Mm-hmm. But the issue is that if you give them so much oral magnesium, then they're going to get diarrhea from it. And how do you tell the difference between, diarrhea from magnesium versus diarrhea from, the graft?
Right. And so in these instances, is home care involved? Are they the ones that are, okay.
Yeah, there's infusion setups. The home care goes there and teaches the patients how to use it, but a lot of times the patients then learn how to hook up their magnesium every day. So they don't need a daily visiting nurse, but these are well-organized processes before they leave.
Okay, so what's the percentage of patients receiving home care, would you say?
Anyone that goes home that has a line, so everybody gets some sort of home service, yeah.
Okay, so you're saying, just trying to understand based on, comparing to past respondents. So a lot of people are followed up in outpatient clinics or infusion centers. Does that also happen, or you're mostly?
Yeah. Mm-hmm. The home care is only for the IV management.
Okay.
Purely for that. If they, just for their PICC line, their electrolytes, but they come into the clinic twice a week still after they leave.
Okay. And what's the percentage of patients receiving home care?
I think just about everyone.
Really? Okay. Okay. Sounds good. And does your center, well, actually, before I ask this question, does your center only cater to local patients or also remote patients?
What do you mean by remote patients?
Well, I guess every center I've spoken to has a certain radius patients need to stay within during their transplant follow-up care. Does that apply to your center also?
Yeah, yes and no. So all of our patients are quote local, but some of my patients drive 90 minutes. They come from Rhode Island or they have to drive still over an hour. So I don't know if that's considered local, but they do it twice a week. They just come in.
Okay. So there's no patient. What I mean by remote, a better definition, if you had a remote patient, you provide assistance, housing assistance for them to stay within a local, set.
Yes. We do have that option as well.
Okay. Is there a guideline? Is there a radius beyond 30 minutes, beyond 1 hour, or is it anything like that you're aware of?
So there isn't, I don't think there's a specific guideline. So if you live within the area that you have to be able to come to your appointments twice a week. Mm-hmm. So, so we've had patients from like another country come, and then